Okay, so we are live now. Welcome everyone, and thank you for joining the talk this evening. We have Professor Graham Jackson talking for us this evening, and he's a consultant haematologist specialised in heme malignancies. It's just a reminder that all of our speakers are volunteering, and we're very grateful and lucky to have Prof here with us this evening, giving us his time back out of almost retirement to talk for us this evening. So everyone, without further ado, I will hand over to Professor Jackson.
Thank you, Miranda, and it's a great pleasure to be here. And I just said to Miranda that if anyone wants a PDF of these slides, I'm very happy to share them. I'm also very happy to answer any questions. I do have to be away by 10 to 8, but if people want to email me afterwards on my NHS email, I'm happy to answer questions. So I'm going to talk about myeloma, and I think a lot of people find multiple myeloma a really difficult disease to understand. And actually, when I was a medical student and through my medical training and before I became a haematologist, and even actually when I became a haematologist at first, I really struggled to understand multiple myeloma. So I hope I can debunk some of the mystery around it and help people have a better understanding of this disease, which is one of the most common hematological cancers, and is quite important for people who may not actually go into hematology, because it is one of those cancers which abuts against numerous medical teams, oncology teams, cardiology teams. So it is a disease where even if you're not a hematologist, you may well come across it. So this is my title slide, and I've kind of shown you the enemy. This is the enemy. These arrows point to the malignant plasma cell living within a fairly normal looking bone marrow background. And multiple myeloma is a disease that lives in the bone marrow. And that actually provides a lot of diagnostic difficulty, because as we will see, it rarely comes out of the bone marrow. So unlike, say, a breast cancer, which might present with a lump, or prostate cancer, which might present with urinary difficulties, or a colon cancer that might present with bleeding or pain, multiple myeloma, when it does present, often presents with very non-specific symptoms and does not present with a symptom that is characteristic in the way that many other cancers do. Okay, so let's just talk about it. It's a cancer of the plasma cell. As you will know, the plasma cell is the antibody-producing cell, which is the final common pathway of the immune system, particularly the B cell immune system. And normally, plasma cells will produce antibodies. So if, for instance, we're all vaccinated, the end result of vaccination will produce lots and lots of plasma cells, which will produce lots and lots of antibodies against the vaccine. But multiple myeloma is a cancer of the plasma cells. So the plasma cells in multiple myeloma do not produce a useful antibody, and all the antibody they produce is identical and useless. I'm also going to touch on a number of other disorders, because actually multiple myeloma is part of a family of disorders. You'll know of monoclonal gammopathy of uncertain significance. It can present as a single lump in the bone marrow called a plasmacytoma. Myeloma and its associated disorders are the commonest cause of amyloidosis in the form of AL amyloidosis. And rarely this disease can present as a very aggressive form of myeloma, namely plasma cell leukemia. So what else do we know about it? Well, multiple myeloma, as I say, is a clonal plasma cell neoplasm. It produces a monoclonal antibody. And it's twice as common in terms of epidemiology in populations of African descent. All patients have a pre-existing monoclonal gammopathy. And the way I kind of sometimes explain this is that the monoclonal gammopathy is a little bit like having an abnormal cervical smear. Many people can have an abnormal cervical smear, but do not all go on to get cervical cancer. but all people who have cervical cancer will at some point have had an abnormal cervical smear. And as I said, in most cases, this disease is only found in the bone marrow. Some more facts about multiple myeloma, which are make it a difficult disease sometimes for us when we are meeting patients for the first time, is there are a lot of delays in the diagnosis of multiple myeloma. And for the reasons that I stated before, they often present with very non-specific symptoms. The commonest symptoms can be fatigue, back pain, general malaise, and obviously GPs see lots of patients with back pain, lots of patients with general malaise, lots of patients with fatigue. And there are no characteristic symptoms of multiple myeloma that makes the disease easy to spot. So for multiple myeloma patients, they have to make the most visits to a GP from the first symptoms to getting a diagnosis. And of all the cancers, multiple myeloma patients have to wait the longest time from first symptoms to a diagnosis. And again, for those of you online who may not be going on to be hematologists or even oncologists, multiple myeloma is the cancer that is most likely to present in the emergency room as a medical emergency. The good side of this is that multiple myeloma is the cancer with the most rapidly improving prognosis of all cancers over the last 10 years. So that's a little bit of an introduction. Here's just a few more details. There's around about 6,000 new cases of myeloma annually. It forms 2% of all new cancer cases. Around 3,000 patients die from multiple myeloma each year. And the peak rate is about 75 to 80 years, but it can occur at any age. And I've certainly seen 18-year-olds and 21-year-olds present with multiple myeloma. And as you see there, the 10-year survival rate has improved from 5% in the 70s to 33% about 5 or 6 years ago. So dramatic improvements in outcome, but still a lot of work to be done. This is the age distribution by age and sex, red male or orange color female, and you can see the peak incidence is around about 60 to 70, but with the most common in terms of percentages in the 70s and early 80s. So it is a disease of the older patient, and it is slightly more common in males than females. We don't know the causes. I've mentioned the impact of racial origins on the epidemiology, but otherwise causes remain uncertain. It probably may have some relationship to radiation, agriculture. It is more common in farmers, people who work in the petrochemical or metal industry or fuel industry. And it is more common in families where another family member has MGUS or multiple myeloma. So there is a familial or genetic factor, although the familial and genetic factor in multiple myeloma is relatively weak. It's not a strong factor for causation, but it is there. So as I said, it's a neoplastic proliferation of bone marrow plasma cells. So it presents, and it's actually easy to detect. And so one of the frustrations is that although the symptoms are very non-specific, the diagnostic test is very simple. It's a measuring the immunoglobulin levels in the serum or in the urine. And almost inevitably in multiple myeloma, in 99% of cases, you will find a paraprotein in the blood or the urine. So the actual test to give you the hint that the disease is there is incredibly simple. So one of the things that we try and encourage people to do is, even if multiple myeloma passes through your head as a vague differential diagnosis, then just do the test, because it can easily be missed. It presents with these proteins in the serum and urine, but more importantly, one of the things that multiple myeloma does is it loves to live in the bone marrow. And as it sits in the bone marrow, it gradually destroys the bone structure around it and causes what we call lytic bone lesions, and we'll see some of those in a moment. And obviously the characteristic final diagnostic test is to do a bone marrow, and on the bone marrow you will see an excess of plasma cells. So these are plasma cells. They proliferate, they secrete immunoglobulins, and as I've said, they influence bone turnover, and we're going to come back to that. But basically, multiple myeloma will cause osteoporosis, will cause lytic lesions and fractures, and that is part of the symptomatology and the difficulty these patients have. So just a brief reminder, I'm sure you don't need this, but this is an immunoglobulin molecule. You'll know that an immunoglobulin molecule has two heavy chains and two light chains, and the two ends of the Y are the variable regions that bind the antigen, and the FC tail is the signal to the rest of the immune system to come and kill whatever the variable regions are targeting. Now, in multiple myeloma, because it's a tumor cell, the apparatus for putting together immunoglobulin molecules isn't perfect. So one of the important things that you have to think about in multiple myeloma is that actually, although the tumor produces full immunoglobulin molecules, it is a poor manufacturer, if you like. So a normal plasma cell will produce intact immunoglobulin in large numbers, but a malignant plasma cell will often produce intact immunoglobulins, but will produce vast excesses of the light chain. So if we go back, the light chains are these things, and if we go forward, you'll see here this cartoon of a plasma cell shows it producing an excess of these light chains, which are excreted into the bloodstream. And you can measure both the full immunoglobulin protein and the light chains from blood tests. So I thought we would, just before we go on to multiple myeloma, talk about making sense of blood results. So let's say you've sent off a blood result to the laboratory and you've got a paraprotein result coming back. And I'm just going to talk a little bit about how you might interpret this, because not all paraproteins are multiple myeloma. So first of all, the most common condition that is related to multiple myeloma is this condition called monoclonal gammopathy of uncertain significance. What does that mean? Well, it means patients have a paraprotein, but they don't have multiple myeloma. And the uncertain significance is you do not know if that paraprotein heralds a patient going to have multiple myeloma or not. And MGUS is defined as people who have low levels of plasma cell in their bone marrow. The paraprotein levels are very low, and they have no evidence of myeloma-related damage, and they have no symptoms. So this is monoclonal gammopathy of uncertain significance. They have a paraprotein, but it's low. They may have plasma cells in the bone marrow, but they're not common, and they have no evidence of myeloma-related damage. And just to show you how common MGUS is, this is an age incidence from a population study that shows you that by the time you get to 70, 3% of women and 5% of men will have MGUS. By the time you get to the age of 80, if you're doing blood tests, 5% of women and 7% of men have a paraprotein. So these paraproteins are actually incredibly common. And as our population ages, we find more and more patients with MGUS. So we have to work out which are patients who are going to go on and get myeloma and which are patients we do not want to worry and we can leave well alone. So we do a number of tests just to try and assess the risk. You don't need to know all of the details of this, but basically, if you have a low level of a band, it's an IgG MGUS, and the light chain levels in the blood are very low, then, and this is most patients, then the chances of them getting multiple myeloma over the next 20 years is 5% or 1 in 20. And the chances of the patient dying of multiple myeloma over the next 20 years is 1 in 50. But if we then look at patients who've got higher risk, these are patients who've got a bigger level of paraprotein in the blood, they've got more light chains in their blood, and they've got IgA MGUS, then you can see these patients have a 60% chance of going on to get multiple myeloma and a 25% chance of dying of this disease. So when we as haematologists come across a paraprotein, we want to know what level it is, what type it is, and how much light chains there are in the blood. If the patient is low risk, we never see these patients again, and they probably will get annual blood tests with their general practitioner. However, as haematologists, if they have 2 or 3 risk factors for disease progression, we will hold on to these patients and monitor them because they have a significant risk of going on to get multiple myeloma and dying from multiple myeloma. And this just brings me on to the fact that all patients who have multiple myeloma will have had MGUS detectable prior to their diagnosis. And this brings about some discussion about whether we should have a national screening study for multiple myeloma, particularly given how difficult it is to diagnose. And you'll see this was a study done by the US Army where they basically bled 70,000 troops for many, many years. And when they found patients, some of these troops went on to get multiple myeloma, they went back to look at their blood tests, and you can see they could find MGUS detectable for up to 8 years before they got their multiple myeloma. So we know all myeloma patients evolve from an MGUS state. Now, I'm not going to go on about the genetics of the disease because that can be regarded as quite complex, but actually we know a lot about the genetics of multiple myeloma, and it is a truism of all cancer care now that the genetics of the tumor, which obviously differ from the genetics of the normal cell, but the genetics of the tumor give us really important clues about prognosis. They give us really important clues about potential treatments. And they also show us how tumors can develop. So we know as multiple myeloma, there are a number of primary genetic abnormalities within the genetics of the tumor cells, usually involving a tumor promoter gene and a immunoglobulin molecule. So you'll see the 14 T14, so 1114, 414, 614, 1614, 2014. These are all where tumor promoter genes are put against the promoters for immunoglobulin production, and this is what drives the initial tumors. But then as the tumors develop, they become more complicated with increasing numbers of genetic abnormalities, and these increasing genetic abnormalities fuel a more aggressive tumor phenotype as the patient goes through their treatments. And for those of you who want to be haematologists, this is something that is endlessly fascinating. And as I say, one of the great developments in all oncology, but particularly in haematology, is understanding the genetics of a disease has massively increased our ability to successfully treat these diseases. And I've seen a question from Dr. Addy, who's listening, who's asked about, will it be detected on the Gallery test? And yes, we have had some patients come through to our new patient clinic where their myeloma has been detected on the Gallery trial. Also, what sometimes confuses us is that some patients can have the tumor, i.e. multiple myeloma, but the tumor is sitting in the patient's bone marrow but not causing any problems or damage, and this is called asymptomatic multiple myeloma. And actually, this is a benign form of the disease, and this actual form of multiple myeloma can be watched without needing treatment. So we do have some patients, and it's quite difficult sometimes to explain to them, but we do have some patients where we say, well, we've diagnosed multiple myeloma in you, but we can find no evidence it's causing any problems. And for these patients, watching and waiting is actually a very reasonable treatment option, although it's difficult sometimes for a patient to get their head around that concept. And we've had patients who've lived with multiple myeloma without treatment for 5, 6, 8, 10 years and longer, and the disease has never evolved into a more aggressive form of the disease. So one of the interesting things about multiple myeloma is it can behave in a relatively benign fashion. That's not the case for most patients, but there is a small subgroup of about 10% of patients where myeloma itself behaves in a very benign fashion. To be diagnosed with multiple myeloma, you have to have more than 10% plasma cells in the bone marrow and or the paraprotein level has to be above 30 grams, or you're producing a lot of light chains which are appearing in the urine. But importantly, these patients don't have any evidence of bone damage, any anemia or CRAB criteria, which I'll come back to in a moment, or myeloma defining events. And these patients can be watched. This graph just shows the probability of MGUS patients presenting over 20 years to multiple myeloma and the possibility of myeloma, smoldering myeloma or asymptomatic myeloma progressing to active disease over 20 years as well. And you can see, if you diagnose smoldering myeloma, 50% of patients will need treatment within the next 5 years. But that means that 50% of patients won't need treatment over the next 5 years. If you look at 10 years, it will show you that 66% of these smoldering patients have gone on to need treatment. But again, if you look at that the other way, 33% of patients do not or have not had any treatment. And again, at 15 years, there's still 25% of patients who remain untreated. So again, it's a truism of oncology, but particularly for multiple myeloma, that you can isolate patients who do not require therapy. And clearly, the best and safest treatment is no treatment at all. So this just sums it up. So multiple myeloma itself often can present with high calcium. We're going to come back to that in a moment. Renal problems, which we're going to come back to. Anemia, because the patient's bone marrow is not functioning properly, so they often have a very low hemoglobin at presentation. And bone disease, which we're going to come back to as well. The other frequent abnormality with multiple myeloma patients is that although they produce lots of paraprotein, the immunoglobulin that the tumor produces is functionally useless, but suppresses the immune system in a way that makes these patients very open to infection. And you have to think of these patients as being fairly significantly immunosuppressed. Okay, so let's talk about symptomatic myeloma. What do patients with multiple myeloma present with? Well, they can certainly present as medical emergencies. I'm just going to talk about the medical emergency they present with. They can present with acute renal failure. They can present with high calciums and hypercalcemia, and I'm sure some of you have dealt with patients with high calciums. They can be very difficult patients to deal with until the calcium is corrected. They can very importantly present with spinal cord compression, and actually multiple myeloma is the commonest cause of malignant spinal cord compression. And they can present to orthopedics with pathological fractures. So the important thing about these medical emergencies is that if you treat the patients promptly, if the emergency is recognized very quickly, then actually these problems can be reversed, and particularly the renal failure is a huge emergency. And if you treat it promptly, you can make the difference between someone with myeloma living a fairly normal life, albeit on treatment, and someone with multiple myeloma facing treatment and being on dialysis. So there is a very important lesson around treating patients with multiple myeloma who present with renal failure as an absolute emergency. And we would almost start their treatment on the day the diagnosis was suspected. Now, why do myeloma patients get renal failure? Well, it's quite a lot to do with this excess of light chains that are produced. And I'm just going to go back to just reminding you that these light chains are very toxic to the kidney. Why are they toxic to the kidney? Now, you never thought tonight you'd be getting a picture of a glomerulus in an oncology talk, but here's the glomerulus, and you can see that although proteins don't get filtered out into the urine, and we know that the glomerulus is very good at making sure we don't lose protein into the urine, the light chains that myeloma produces are so small that they escape through the pores of the glomerulus into the urine and the collecting ducts. And if we look further, you'll see that you get lots of light chains going into the urine. They go down through the proximal convoluted tubule into the distal tube, into the loop of Henle. And this is where urine is concentrated and water is extracted. Now, if you have a lot of protein in a water solution and you gradually take the water out, what happens is the protein solution becomes a gel, and the gel absolutely bungs up the nephron. And each time that happens, the patient loses a nephron. And the end result of that is you get these casts forming in the kidneys. And once they form, there is an inflammatory condition that is set up against the casts, and the kidney is gradually destroyed. So all of the problems are because if a patient has very high levels of light chains, that means high levels of protein are delivered to the kidney. The kidney isn't used to dealing with lots of protein. And if the urine needs to be concentrated, you get gel forming and you lose nephrons very quickly. This can be exacerbated by hypercalcemia. We're going to come back to multiple myeloma being a destroyer of bones, and it produces very high calcium levels in some patients. It can be made worse by dehydration. So often the first treatment we give these patients is very high fluid loads. That dilutes the light chains in the urine and stops them forming the gels. We have to stop nephrotoxic drugs, particularly non-steroidals. Often patients in myeloma are on non-steroidals because they present with bone pain. We have to treat any infection, particularly urinary tract infection, and we have to be watching out for gout. As you will all know, that many malignancies, particularly haematological malignancies, can be associated with very high urate levels and the potential to get gout. So we treat as an emergency. High levels of fluid are very important. You have to bring down the calcium, avoid aminoglycosides, ACE inhibitors and non-steroidals, monitor for infection, keep the calcium coming down with bisphosphonates, watch the urate, and check for amyloidosis. Now, I just wanted to mention briefly about amyloidosis. Again, it's a subject that is much beloved of medical exams. It is more common than you might imagine, and you have to think of amyloidosis in patients who might have macroglossia, cardiomyopathy, nephrotic syndrome or kidney disease, malabsorption, and also neuropathy. And amyloidosis is most commonly associated with paraproteins, and it's the AL form of amyloidosis. So in our myeloma clinics, we always will deal with amyloidosis patients as well, because it is treated in the same way as multiple myeloma if it is AL amyloidosis. So for amyloidosis, if you've got unexplained nephrotic syndrome, unexplained neuropathy, macroglossia, or congestive cardiac failure with an abnormal echo and no other cause, think of amyloidosis. And if you think of it, then you need to arrange a biopsy, and the biopsy is very distinctive. So that is a little bit about multiple myeloma and renal failure. And I would say that now one would regard a multiple myeloma patient ending up on dialysis as a failure somewhere along the line of medical management. And certainly we would be very upset if we got a multiple myeloma patient, even one presenting with very significant renal impairment, if that patient didn't escape dialysis. So the other medical emergency myeloma can present with is the consequences of bone problems. So hypercalcemia, you know the symptoms of hypercalcemia. So myeloma patients can present with hypercalcemia, confusion, abdominal pain, dehydration, vomiting. They can be very poorly and very difficult to deal with because they're often incredibly confused, and it's very important to bring down the calcium very quickly. And obviously the bone disease can cause fractures and, importantly, spinal cord compression. The key thing with spinal cord compression for any budding oncologist and indeed any physician is that spinal cord compression, if you ever think of it, you must make sure the patient gets an MRI scan that day and as quickly as possible. You should never let the sun set on a patient where they might have spinal cord compression without getting an MRI and preventing further cord compression. So myeloma bone disease. Myeloma loves to live in bone. It only lives in bone, really. And you know, these are older x-rays just showing how the bone gets thinned. And this is a patient who eventually fractured their femur. And you can see how the bone is whittled away within this femur. And here's a skull with deposits of multiple myeloma. And you can see how the bone has dissolved around the tumor. And just to show that a little bit more graphically, here's the x-ray of a pelvis of a patient of ours, and all the patients who've shown these x-rays have given us permission. This is a normal pelvis, and this is the pelvis. And once you get your eye in, you can see that the ossification of this side of the pelvis is much reduced compared with this side. And if you then do further imaging with a CT scan, you can see that this patient has a huge tumor, which is a myeloma tumor in that wing of the pelvis. And you can see the tumor is infiltrated through the acetabulum into the left hip joint. So you can really get a feel from these pictures of the level of bone destruction that goes on with the patient with multiple myeloma. That can lead to fractures, and particularly vertebral fractures. We've got better at imaging this disease. So here's a plasmacytoma coming out of the rib cage. There's a tumor coming out of the vertebral area. Occasionally you can get disease within the brain. And very, very rarely the disease emerges out of the bone marrow into the liver. But there you can see some great hotspots of bone disease on this PET CT scan. Why do we get this situation? Well, there is a very important mismatch. So normally our bone's very, very active tissue, and it is like a kind of mad DIY person who is constantly knocking down walls and rebuilding them to make them stronger. And our bone is very active. It's been said we replace our skeleton every 3 to 5 years, which gives you a sense of how active bone normally is. And normally there are two sets of cells. The osteoclasts destroy the bone, and then the osteoblasts come and remineralize the bone and make it stronger. So in multiple myeloma, the tumor produces osteoclast activating sets, proteins, which basically make the osteoclasts go into hyperdrive, and they destroy lots and lots of bone. And on the other hand, they produce sedatives for the osteoblasts. So instead of the osteoblasts and osteoclasts working in perfect harmony, you get the osteoblasts, the osteoclasts working really, really hard and destroying the bone, but the osteoblasts go to sleep. And this allows the bone around the tumor to be destroyed. And this is probably part of the interaction between myeloma and the bone, which makes the bone area a very nice place for multiple myeloma to live and survive. And so these are the osteoclast activating factors, TNF-beta, IL-1, IL-6. So that produces the hypercalcemia and all of the bone problems. And we can, this just shows you the sort of symptoms that multiple myeloma presents with. So 70% of them will have anemia. I mentioned that they're immunosuppressed, so they have a massive increased risk of infection. 20% of them present with CKD5 renal failure, 40% CKD4 bone disease. Lytic lesions are found in 80 to 90% of patients, with 80% of patients having bone pain, 50 to 60% of patients presenting with fractures, and around 15% presenting with high calcium levels. So you really get the feeling, what is a myeloma patient going to present with? Fatigue, anemia, infection, renal impairment, and the consequences of bone destruction. How do we treat the bone disease? Well, in the first instance, hypercalcemia, we treat it with IV fluids, steroids, and bisphosphonates. But bisphosphonates were then shown to actually improve the patient's bone pain and used long-term, improve the patient's quality of life. And if we look at some graphs showing that zoledronate, the most powerful bisphosphonate, massively reduces the amount of bone disease that myeloma patients get. And now with modern therapy, although we can't reverse the bone disease that's often happened before presentation, with active treatment and with an active bisphosphonate regime, we can prevent further bone disease from happening. And this just shows if you've got bone disease at presentation, you can stop it from happening with zoledronate. And most importantly, if you get a patient without much bone disease, you can see that they are not going to have bone problems in the future. So again, a common theme, if myeloma was diagnosed earlier, the patient's less likely to have renal impairment, less likely to have hypercalcemia, they would have healthier bones, and they could even have an even better quality of life and enjoy the ongoing benefits of the improvements in treatment. And just for the final few minutes, just to talk about how this improvement is going. So this is survival curves for multiple myeloma from 1960 through to 2010. And you can see that there was very little improvement through to about 1995. And then we started to get some new and more effective therapies. And you can see that the improvement in overall survival is dramatically improving, although there's still patients dying early, and we haven't yet reached a plateau which suggests we're curing any of these patients. This is stats from England and Wales, just looking at that 5-year survival rate, 11% in the 70s, maybe 15% in the 80s, 20% in the 90s, up to 25% in the 2000s, 2005, you're up to 33%, and now 47% 5-year survival, 33% 10-year survival. So a dramatic improvement in prognosis, and that's just shown a different way here with the 1-year survival rate, the 5-year survival rate, and the 10-year survival rate. And you can just get a sense of how tough things were back in the 70s when only 37% of patients survived 1 year and only 10% survived 5 years, whereas in 2010, 76% were surviving first year, 47% and 32%. So a dramatic improvement. One of the reasons we haven't seen better improvements is that the most of the improvements we've seen are in our younger and fitter patients, and people in all walks of oncology will tell you that actually the hardest group of patients to treat are the older and frailer patients, where they often bring frailty and other comorbidities which make it difficult for them to benefit from the treatments that really help the younger, fitter patients. And again, this is just data from the Cancer Research UK showing the 5-year survival for younger patients, 5-year survival for 50 to 60 patients, 5-year survival for 6-year-olds, and look at the difference once you get to over 70s and over 80s. So we still haven't made a huge or major impact in older and frailer patients, which is something we're working hard to change. It's a disease that goes through a number of periods of relapse and remission. We don't cure it. Eventually, it does become a refractory disease, but we definitely can offer first, second, third, fourth, and fifth lines of therapy. So we are trying to make it a chronic disease, if not a curable disease. I've hinted at this. There are many ways in which we can assess prognosis. All of these factors can herald very poor prognosis. A high beta-2 microglobulin, a low albumin, adverse cytogenetics, LDH, age, peripheral blood plasma cells, frailty, and extramedullary disease all herald patients who might do very, very badly. And we can put these together into risk groups. I'm not going to go into all of the details of this, but needless to say, we can isolate patients who are going to do well in blue and patients who are not going to do so well in grey. And sometimes we can treat these patients more aggressively, but also this will colour some of the conversations that we have with some of our patients in terms of their prognosis. And also the final factor that defines risk is that if they are resistant to some of the chemotherapies that we have, then they also do very, very badly. So I'm going to stop there. I hope I've helped you understand myeloma a little bit better. I think the two key take-home messages are there has been dramatic improvements in outcome, but importantly, multiple myeloma is not seen universally just by haematologists. It can easily present as a medical emergency, hypercalcemia, or renal failure, or as amyloidosis to cardiologists, or as a fracture to orthopedic surgeons. And it can present as an oncology emergency with spinal cord compression. So it is one disease to think about, even if you're not going to go into haematology as a career. Now I'll stop there. I see there are a couple of questions just coming through, so I'll acknowledge them whilst I'm finishing talking. So for Dr. Roy, what is Waldenstrom's macroglobulinemia? This is a type of lymphoma. It is not the same as multiple myeloma, and it is treated as a lymphoma. What marks it out as being similar is that it produces a paraprotein, but in this case, it's an IgM paraprotein. So an IgM paraprotein usually goes with Waldenstrom's, which is a type of lymphoma and is not myeloma. And taking Dr. Addy's question about is denosumab safer than bisphosphonates in patients with nephropathy? Potentially, yes. And denosumab is something we will use in patients with very severe renal impairment if we can't use bisphosphonates safely. And with that, I will stop. Thank you.
Thank you so much, Prof Jackson. I'm sure you'll all agree that was a very clear and helpful talk to listen to. I'm going to drop the feedback link in the chat now. If everyone could give feedback, you'll get a certificate as well for attending. I know you have to be off, Prof Jackson, so thank you very much for your time this evening.
Well, Miranda, I'll say two things. Firstly, if anyone wants a PDF of the slides that they find helpful for their personal use, I'm very happy for you to share them if I email them to you. And I would also be very happy if people wanted to ask questions via my NHS email address if they wanted to. With that, I'll say good night and thank you very much for listening. I hope you all have a safe journey home if you're not at home, or a wonderful ongoing evening.
Thank you. Thank you very much. Bye.